Hi there, I'm Heather Cassie. I'm a researcher at the School of Dentistry in the University of Dundee, and I'm also this Institute Postdoctoral Fellow, exploring choosing wisely in dentistry. Now, before I start on the presentation, I just wanted to pose two questions for you to consider. How often do you think you need to attend the dentist for a checkup? And how often do you think you need a scale and polish? And the reason I've asked you to reflect on these questions is because, in actual fact, these two dental treatments, which are offered routinely, stem not from scientific evidence, but actually from advertising and ingrained behaviour. The 6-monthly dental recall interval in particular can be traced back to a 1930s radio jingle featuring Amos and Andy, where they said, brush your teeth twice a day, see your dentist twice a year. And in the 50s, dental products such as Pepsodent advertised a 6-month checkup alongside the use of their products. And so at the inception of the NHS, it was actually advertising and not evidence that informed the frequency of dental recall visits, as well as funding models to support these. In 1977, the Lancet famously challenged the scientific basis for a 6-month exam. Yet 46 years on, these treatments are still being offered routinely. More recently, clinical trials and subsequent Cochrane reviews have called into question the evidence of their clinical benefit to patients. The interval study, which you can see at the top here, explored dental recall intervals for adults. And what they found was that a standardised 6-monthly checkup was unlikely to improve oral health when compared with a risk-based personalised recall interval. So that could vary anywhere between 3 and 24 months. The iQuad study, which you can see at the bottom, explored the provision of scale and polish. And what they identified with high certainty evidence was that it made little or no difference between regular planned scale and polishes when compared with no scheduled scale and polish for the early signs of gum disease. And so these are the two dental treatments that I'm going to explore as part of my work. And if we consider some of the external drivers for change, in the current climate, it's crucial now more than ever that we ensure we've got a model of care which is both environmentally and socially sustainable, but also that healthcare is evidence-based and offers good value. One way of addressing this is through the Choosing Wisely initiative. Choosing Wisely is a global initiative which has been used extensively across the US and Canada, but less so in UK and dentistry. Choosing Wisely has really evolved from an initial campaign which encouraged the creation of lists of potentially low-value tests or treatments, and encourage patients and healthcare professionals to call these into question. And now it very much promotes healthcare professionalism and encourages a dialogue between healthcare professionals and patients to reduce unnecessary treatments. So really involving both as partners in a shared decision-making process. And I suppose if we think about why, what could be the benefits of doing this? Well, actually, if we look at pre-pandemic figures in Scotland, in 2018-2019, there were 2.8 million checkups, which cost the NHS in excess of £25 million, and 2.2 million scale and polishes, which cost the NHS and patients combined £31 million. So if even a fraction of these costs could be redistributed to other more clinically beneficial treatments, this could address some of the current NHS challenges. So my study is a multi-method study. It's underpinned by the Choosing Wisely de-implementation framework and the theoretical domains framework, so very much utilising tools from behavioural science. The study has 3 objectives, and the first one I'm going to focus on today, which is to explore the barriers and enablers to reducing the routine provision of these 2 dental treatments in practice. So in order to do that, I conducted 68 interviews. 14 patients from across the UK, 20 dental team members from NHS practices in Scotland, and then 34 other stakeholders involved in the policy, education, planning, and service delivery surrounding these 2 treatments. And I'm just going to share some of the findings now. So in terms of the patient interviews, these were some of the broad themes that were identified. The routine or habitual behaviour of attending every 6 months was really evident. This is a behaviour that's been ingrained in people from childhood, and there is an assumption that it's based on evidence. There was concern about moving to a risk-based recall interval, which might mean being seen less frequently, might result in something being missed, or teeth not feeling as clean as patients are used to. It was also suggested it might demotivate patients to look after their own oral health. There was also a sense of a lack of confidence and a lack of knowledge around asking questions. This was linked to patients feeling not only did they lack the knowledge, but they felt uncomfortable in the clinical environment, and they were aware of the time pressures that the dental team were under. However, there was huge trust in the profession and a desire to increase their knowledge in order to support having a conversation about their own oral health. And I just wanted to include this quote from one of the patients I spoke to that really illustrates that habitual behaviour. They said, "You go routinely, you go for your checkups, and that's just what you do." When it came to the findings from the dental team interviews, there was a really strong sense of fear attached to reducing these behaviours. There was fear in general around change or having their system changed. There was fear that patients would respond negatively, and if they didn't provide a certain treatment, that the patients would go down the road to another practice who would. It was really clear that no one dentist wanted to change their behaviour without the reassurance others would do so too. There's also a fear of loss of revenue, and in Scotland in particular, the fee-per-service funding system means that some dentists fear not being able to claim for these routine treatments, which could significantly impact their business. There was also concerns about the longer recall interval, about not spotting something like an oral cancer, and linked with that the responsibility of having to assess each patient's risk level to determine how often they should be seen, coupled with the fear of litigation if they get it wrong. Finally, dentists are really aware of the privileged position they are in to be able to see patients routinely and the holistic relationship that they're able to form with them. And again, just to look at some quotes, we've got an associate dentist at the top here that says, "I wouldn't want to be the first to jump. I don't want to be a pioneer." And then a principal dentist and practice owner at the bottom, highlighting the consequences for dentists might be that they're terrified of loss of earnings. Finally, for those responsible for policy, education and service delivery, the barriers and enablers really focused on the immediate priorities facing NHS dentistry. So access, funding models, the workforce, but also shifting the focus from disease management to disease prevention. There was an acknowledgement that there are inherent cultural challenges which need to be addressed, including that intrinsic link between the fee and the service provided, as well as the value that's placed on the profession, their health and well-being, and what success looks like to them. Communication was a strong theme, and creating an environment where patients and professionals feel comfortable to have conversations about their treatment options. But actually what appeared to underpin it all was a lack of clarity and strategic direction about what NHS should look like going forward. Should it be free at the point of access, or is a move to a core service model needed? And again, one stakeholder highlighted, prevention is still the most cost-effective thing that we can do. There has to be some incentive for just giving time, talking and educating patients. We need to help them fall back in love with delivering NHS care. So having identified these barriers and enablers, I'm now taking a theoretically informed co-design approach to develop interventions to reduce the routine provision of these treatments. And I just wanted to share this poster, which represents some initial discussions I've been part of as part of a wider group discussion around the implementation of the interval trial findings. And you can see there's a really strong theme around knowledge, communication and shared decision making coming out of these discussions. One potential intervention, which I'm looking to explore further, is a shared decision-making tool known as BRAN, and that supports a structured conversation between healthcare professionals and patients to discuss the benefits, risks, alternatives, but also what would happen if you did nothing in relation to the provision of any test or treatment. So I just want to thank you very much for listening, acknowledge that this work forms part of a This Institute Fellowship, thank the team there for all their support, as well as my project mentor, Professor Jan Clarkson. Thank you.